you all for being here or joining in via the webcast for today's town hall presentation. I have a lot of things to cover, but hopefully we'll have a little time at the end for questions. I know we've had a few that have come in through the web portal, and certainly want to try to get those addressed, as well as any questions from the audience. So this is what we have on the agenda today. We'll do some Way to Go awards, talk briefly about the UCount employee survey, where we stand with that. A quick welcome to Chief Adcock. So glad that he's here. So the slide has a little more information about his background. Absolutely. Best care update, where that stands, what we know about FY18 and potential recognition, and where our focus lies for FY19. Then talk about our priorities for fiscal year 19. Now, these are the priorities that have emerged through our strategic planning process. And we'll talk more about that with that particular slide. A quick update on facilities, just some pictures of where we stand, some comments from me. And then we'll close with the financial report, outcomes for FY18, at least what we know today. And then where we are with regard to the budget plans for the current fiscal year that begins September 1st. So we'll get right into it. I always love to start with the Way to Go awards. So, and again, one of the reasons that I do this during town hall, I know it takes a little bit of time, but what I'm hoping is that our department chairs and managers and supervisors and vice presidents and other leaders, whether they be in a faculty or administrative role, are emulating this, recognizing people in their work groups during the course of staff meetings or other times that people get together. Now, one of the things that happens in big institutions is sometimes, particularly when things are busy, they're not going exactly according to plan, a little cynicism sets in. Does that surprise anybody? You think we might have a little cynicism today based on everything that's happening and all of our challenges? Well, absolutely. And of course, it's a little easier, perhaps we're prompted to be a little more cynical and sarcastic when that's one of the only ways that we can get any attention or be recognized. So I think it's very important recognizing that tendency, and also that, for us, and just about everybody in healthcare and education and research, like we do it anyway, are going to continue to see challenges for the foreseeable future. A lot of change is occurring and a lot of changes on the horizon, and change is hard for human beings. And so we're going to continue to be challenged. It'll be easier sometimes to be cynical and sarcastic than it is to be positive. But we should resist that urge, and we should continue to recognize each other for the good work that we do. Every day, I hear examples of great work at UTMB. Unfortunately, and maybe this is just because of my information channels, I'm not hearing as much about recognition of that good work. So I want to encourage everybody, and I'm not saying everybody is guilty of not providing recognition. I think everybody, certainly the people I know in this room, are doing a good job with that, but I think we can always do better. So let's remember that as we go forward. If you see something great happening, like yesterday and the day before, Mike Schreiner, Donnie Tisdale just was off the charts with his response to the water restriction that was a potential for Jenny Seeley. And I know Mike recognized him. We always said thank you. But little things like that, it was a big thing at the time, but offers opportunities for special recognition to say thank you. Let's just make sure we don't miss those. So anyway, let me proceed with the Way to Go awards for today. Anybody recognize this? You folks from Angleton Danbury probably do. Those of you who were involved. So we had a major roof repair that was occurring up there, and right in the middle, on a very hot day in the summer, in the middle of the repair, one of the workers fell out, and he actually was a victim of heat illness. And so the folks in our Angleton Danbury ER responded, and so I want to recognize them today. Jason Garner, nurse manager, and Rebecca Fief, nurse clinician 3, actually grabbed supplies, IV fluids and tubing, and went running up the ladder to provide immediate relief to this stricken worker. They actually started IV fluids, they started communicating with docs in the ER, providing care to this individual to begin the recovery process while they awaited the Angleton Fire Department's response with a ladder that was capable of extricating the stricken young man from the roof. They were joined by a couple of our police officers, so Lieutenant Rivera and Officer Smith, who provided a lot of coordination and communication support. Brandon Lively and the CT technologist, Matthew Terry, ER technician Glenn Baker, all responded, went up the ladder, were there helping to make sure that not only were we caring for this young man in place, but doing everything we could to quickly remove him from that hot rooftop and into the ER to get care. So please join me in recognizing them. I'll ask them to come forward. Congratulations. Thank you very much. Thank you very much. Are you, sir? Yeah, sure. Absolutely. Love having your picture taken. All right, well, we have to make it look like a wedding photo. So you turn in this way. Here we go. There we go. All right, thank you all very much for showing the true spirit. Appreciate it. And for those of you who don't know, part of the award is the blue shirt. There are no other shirts this color at UTMB. They're very distinctive, or they're not supposed to be. And also a pin that says WTGA, Way to Go Award, which can be pinned to an ID badge or a lapel or something else. So if you see somebody with one of those shirts or pins, please say thank you for what they've done. The next one goes to Savannah Parks, who is our patient resource specialist in our Health Resource Center. Savannah's just done an incredible job since she's been here. All of us who interviewed her were so impressed with her background and skill set when she arrived. And she has done wonders, many times on her own, driving forward the vision for how we can improve the number and type of resources available to assist our patients with all the needs they have while they are here, as well as when they leave. In this particular case, she was nominated for working with the Galveston County Resources Group to work with a number of the support agencies that assist patients and others in Galveston County, making sure that we had connections to them, materials representing what they do available for our patients. So again, just a personal effort beyond day-to-day responsibility that we think deserves recognition. So Savannah, please come forward. And you already have flowers. How marvelous. Congratulations. Thank you. Thanks for all the great work. Finally, Elaine Hester Goodman, who's Nurse Clinician 3 in the Angleton Danbury ICU. I guess the call went out from Galveston back on the 11th of July. We were just, what do we say, slammed? So the ER was backed up with ICU patients in the ER awaiting admission. We were completely full. We had ICU patients in the post-anesthesia care unit, and we didn't have enough staff. And so the call went out from here to League City and to Angleton asking if anybody would be available for volunteers to come assist care for this patient volume. And Elaine responded, said, yeah, I will do that. She ended up driving here from Angleton, didn't anticipate doing that day, showed up, and I guess we asked her, well, you know, what would you like to do? We have all these opportunities. And of course, true to her nature, I think, she said, I'll do whatever you need for me to do, just tell me where I need to go. And so she was assigned to the post-anesthesia care unit, ended up taking care of an ICU patient who was stationed there. And every member of that team talked about how wonderful she was, how she just integrated herself perfectly into the team and did a great job, not only with the patient to which she was assigned, but with all the other patients and with the team members as a whole. So Elaine, please come forward. Congratulations. Have a great day. These particular nominations came from managers who work with these individuals and very appropriate. So again, if you have someone that you'd like me to recognize, I'm more than happy to do that. Just a little description of what happened and we'll review it and then take care of it. So thank you so much. All right, UCAP. So we did complete our all-employee survey. We had an incredible participation rate. You know, usually if you can generate 30 to 40% participation on these, you think you're doing pretty well. We had 64% participation. In fact, Ms. Pardo had to spend a lot of time at pizza parties because of the response, and she was very happy to do that. So all in all, and you know, we weren't really surprised by these, we have an engagement score that is 4.05 relative to the national healthcare average. This is in right at that junction, bottom third, middle third, and then 39th percentile for academic healthcare institutions, so a little higher there. Action planning readiness score, which has to do with how capable we are of actually responding to these results, and also helps to find what we need to do to make sure we can respond most effectively to the information that we've received. Is pretty good, actually. We're pretty ready as an organization to take on the results and try to move forward and address some of our employee concerns. Interestingly, at least from the time that I've been here, these results were the most diverse among the result sets that I've seen. And what I mean by that is we had some groups that were pretty pleased and pretty happy, and some that really are really worried and concerned about their operating context. And faculty constitute the majority of that group. So what we see is a variety of different needs. And so as much as possible, we want to go forward and make sure that our efforts to address those needs are truly focused on the needs of the group. Now, the last time we did an all-employee survey, we had a readiness score, we had recommendations from the group that was helping us at the time, and there was a tiering of the readiness classification, so tier 1, tier 2, tier 3. We have the same thing this time. And what those indicate is the readiness of an individual group, whether it be at the institutional level, the academic enterprise level, the Department of Otolaryngology level. I see Dr. Russell sitting there, so I use that as an example, or some subgroup within that department. It tells us how ready that group is and some of the things, it makes some suggestions based on the tier level about what we need to do to make sure that that group is most capable of responding. We didn't do a very good job last time we did a survey like this in communicating what those tier levels meant. People considered them grades. Some of our managers and some of our employee groups got really mad at us and said, wait a minute, I'm not tier 3. What's wrong with you? I don't deserve a bad score. And then in some cases, managers felt like we were pitting them against the employees. This is not about scoring anybody. This is about looking at the results and thinking about what we need to do to make the best use of the available information. If you have any concerns about that as your group begins to engage the results, please let me or Ms. Pardo, Ms. Sollenberger, Ms. Sagro, Dr. Bardwaj know, and we'll take a look into it and we'll, if necessary, come personally meet with you and your group just so you understand what we're trying to do with these results. It truly is address the needs and desires of everybody who works here. We want to be better as an organization. We know if we don't take care of our people and address those concerns, it's hard to get any better. So please don't worry too much about which tier you fall into. I can tell you, if you look across all of the Office of the President functions, facilities, IT, HR, events, development, all of the groups that report to me, we're tier 2. And so, we're going to take that on, we're going to address it, and we're going to work with all of our leaders to try to understand the needs and concerns of our employees and do the best that we can to address them. So, just please keep what we're trying to do here in mind. This is not intended to be punitive. It's not to point to a manager or work group and say, you or you all have a problem. That's not it at all. What do we need to do to make UTMB a better place, particularly for our employees? So that's the focus of this, and you'll hear more about that as we begin to roll out the action planning. The dates are on here. The managers are reviewing the results with staff. I think that ends this week. To begin response planning after that. We'll hope to finalize all that by the middle of December and then be ready to move forward with all of our action plans after we come back from the end of the year holidays. Okay, the main recommendations, if you look across UTMB, have a lot to do with the perceptions that we have about whether or not we have what we need to take good care of our patients, what we believe about the care we provide. And this is interesting because, we're being recognized more and more for the quality of our care, but some of our folks are concerned about the quality of care we're delivering. Is that a perception issue? Is it truly a resource issue? What's driving our own beliefs about what we do, and how do we address that? From the standpoint of investing in additional or newer resources to the point of really looking at the results of the care we're delivering and comparing those to other places and thinking what's most important, how do we make it better? So again, trying to focus on that, understand what's driving the beliefs of our people and address those as we go forward. And the last bullet here is really a concern for the faculty. We're looking all over the country. We're seeing in academic medical centers similar results for faculty feedback, certainly for physician feedback, no matter whether they're academic, private practice, whatever role they play in. And we think a lot of that's related to the current environment. A lot of change, a lot of challenge. A lot of faculty members and physicians entered into their career with the idea they could be their own boss, pretty much determine what they would do and how they would design their work. And today's systems no longer support that to the extent they used to. And that's a big adjustment for some of us. So again, how do we best enable our faculty members, our leaders, our physicians and providers to cope with these changes and also feel like they have a voice? One of the things I'm always after our leaders, because I think the thing we need to avoid more than anything else is being perceived as issuing edicts for which there's no response. And I hear this all the time. My golly, I was in my clinic and I got this thing, I don't know where it came from, doesn't make any sense at all, it's not consistent with best practice, but they say I have to do it. What idiot designed this plan? Well, some well-meaning person, but maybe with just missed connections in terms of thinking about best practices, at what level, getting all of our thought leaders or planners or experts on the same page and designing something that enables us to move forward more effectively in compliance with whatever standards we need to comply with. So, we have work to do. A lot of it's around communication. We want to avoid that sense of the perception of issuing edicts, but also be able to, as quickly as possible, comply with all of the standards or the needs that we need to comply with to be successful as a healthcare, as an educational, as a research organization. All right, the chief, so happy he's here. I know he's here somewhere. Where are you, Chief? There he is. Okay, he's waiting in the back. So, I haven't heard anybody complain about anything he's done. So I think that by and large, our staff in the police department, our officers are very pleased about his arrival, his approach to policing and keeping our people safe and secure. I know within the health system, he's already taken some actions to make us feel a little safer in terms of access to our facilities and support and care for our staff. And I think there's actually a question about this. Hopefully we'll get to it and I'll let the chief respond to that in a few minutes. But welcome, Chief Adcox. It's so great to have you here, someone with your experience, your background, and just your ideas about what it means to be in a place like UTMB and keep it safe and secure. So thank you. Nice to have you here. All right, best care. And now if I get a little bit too far afield here, Dr. Sharma sitting near the front is going to give me the hook. But at the end of our third reporting period in June, we ranked number 4 in the Visiet Quality and Accountability Study. That's pretty darn good. Remember, we were number 9 last year. Now, we've been invited to attend the big Visiet powwow in October in Las Vegas to learn our year-end results. Last year, when they invited us, they told us where we stood. This year, they're keeping us in suspense. So they've told us, we want you all to be there, but we're not going to tell you what your results are. You have to come to the dinner. I guess they need to sell some tickets. Anyway, we're very excited that we've been invited. We think that perhaps is a hint that we've done pretty well. So I'm going to go ahead and say congratulations and thanks to everybody for the great best care. How about if I just say my personal opinion is that we're going to be a 5-star institution. Is that okay? Okay, all right, very good. Now, we're in the process of changing our description of what we're doing. We said best care is not just for the health system. It's for the whole organization. And one of the reasons we've been able to achieve that 5-star status is because we've gone at it as a whole organization. Everybody here in some way affects what patients think about us. So we want that particular approach to continue, but consistent with what's happening on the national level and some of our own thoughts about what we should be doing, we're transitioning the description of what we're doing so that we'll be considered a high-value practicing organization. Now, we often think about the practice of a provider. But when you truly think about all aspects of delivery of care, and for me, if I move beyond that to education and research or support for our mission work, everything we do is a practice. You know, we do things, we continue to think about what we do, we look at the data about our results, and we adjust to get better over the course of time. So what I'd like for us to do, and certainly all of our executive leaders, Dr. Sharma, everybody would like for us to do, is to think about what it takes to be a high-value providing organization as UTMB. Certainly we're focused on the health system and the things that we can do to drive value and efficiency and effectiveness there, but we want that approach, that context to extend across the organization. Now, within the health system, there are 5 pillars that they're really focused on. And I think for those of you involved in delivery of care or reading about it, you know these are important. Antibiotics. What's the problem we have today? Resistance. Yeah, we all know about that. Injudicious use of antibiotics. So we're thinking about that here. We're thinking about it across the state, nationally. And, you know, heavens, we're a teaching institution. We should have standards that are based on best available evidence and be teaching that to our students and trainees by using those standards to deliver antimicrobial therapy. Unfortunately, here, there's still too much variation. And so, going forward, we're focusing on that. We're not telling anybody yet that they can't do something. But we're asking for justification as to why they think that's appropriate in a certain clinical context. Is that correct, Dr. Sharma? Is that fair enough? Okay. All right, so anyway, these things, the same thing, use of laboratory testing. A lot of what some of us do today is still more based in empiricism than actual evidence-based practice. Let's change that as we go forward. Blood management, same thing. Imaging, if you show up with back pain and a lot of ERs, what do you get? Sometimes even before you get a good physical exam. MR. That's nuts. And the data shows that it's nuts. So let's get that right. Let's get the sequence of events right as we go forward. It goes beyond MR to all forms of imaging. Let's make sure that imaging is in support of making a diagnosis other than some shotgun action because we don't know what the heck's going on. That's probably a little bit of an exaggeration. I apologize. Makes the point. And then finally, opioids. We know this is a national problem. There are far too many deaths from inappropriate use of opioids in the country. So we, like a number of other providers in the country, are focused on this, working with government officials, health officials to think about what we can do to stem the tide of this epidemic, reverse it over the course of time, and make sure, again, we're teaching and using evidence-based practice in terms of administration of health. So that's our focus. High-value practicing organization across all aspects of UTMB, more specific focus in the health system related to these 5 pillars. Make sure we get this right as we go forward. All right, so shifting gears. I mentioned this when I was talking about the agenda. Our institutional planning work really goes on all year long. But as we think about an upcoming fiscal year, we typically start our planning a little after the middle point of the current fiscal year when we're considering the next fiscal year. Of course, we follow that process this year. And along the way, as the health system and the academic enterprise and institutional support areas develop their plans, we started pulling what would appear to be priorities out of those plans and then comparing those across the 3 major parts of the institution. We then convened some different groups, culminating with the convening of an institution-wide planning group in mid-July. And out of that meeting, looking at all of that data information, came these priorities. It's no accident that it's aligned with the road ahead and our pillars: people, values, strategic management, growth, and resources. And if you look at these priorities, look at the similarities to the outcomes of the employee survey. Resources. Let's make sure we have the right resources in place to do what we're supposed to do and make sure that we're not overcommitting resources. Value. Let's make sure that we're generating those high quality and high value outcomes. Resilience. Let's make sure, and again, this is not a focus on saying anything's wrong with anybody. What do we need to do as an institution to create better support structures for everybody who works here so we can better accommodate these changes that we're having to manage? And so we believe that these priorities truly reflect the needs of the institution. By and large, there's consensus among the leaders and people who convened as part of the planning process that these are the major issues for FY19. So you'll see us now rolling out our strategic plans, moving forward with those. We have our budgets intact. But what we want to do at the end of the year is to look at this list and make sure that we've accomplished the major goals associated with these priorities. Okay, so more about these to come. I just wanted you to see that list. All right, let's move to facilities. I've done a pulse video about Webster. We're very excited about this. And something that sort of fell out that we really didn't anticipate. We think it's a nice opportunity for us. It is located up in what we consider a prime area for growth. There continues to be population expansion in that area. It enabled us to expand inpatient bed capacity at a time we believe we need to do that based on the need of our current patient population. We don't have enough beds on the mainland. It's very expensive to build new beds. This is a relatively new facility. We could acquire it with a lease for 15 years with options to buy along the way. Now, sort of as an aside, but related, there's a lot of debate among healthcare providers today about how many inpatient beds we'll need in the future. There's a lot of belief we'll need a lot fewer inpatient beds. There's a belief that we'll be able to leverage technology beginning about 15 to 20 years from now to deliver much of what is considered inpatient care today in people's homes. Now, that's interesting. Change our work model and a lot of other things, but that's the belief. What's the lifespan of a new hospital building we build today? About 50 years. So you're tying yourself, if you build new beds, you're tying yourself into those for 50 years unless you can sell them. But if there's an overabundance of inpatient beds, you're going to sell them to them. So anyway, for a lot of reasons, this was an appealing opportunity for us to expand our geography and capacity at a time when we think our current programs are wanting us to do that without tying us into some of the longer term obligations associated with acquiring those inpatient beds. Now, I've had a few people, and there's probably a number of others who think this, who have expressed anger to me. You sent one of my colleagues away. You eliminated their job at the institution. We could have kept them and used the money that we used for this lease instead to keep them. I understand that sentiment. It's hard for all of us when people we know and love and appreciate leave the institution for whatever reason. But what we're trying to do is to become more efficient. We talked about that before. That need exists. We believe it will continue to exist. We need to use people and other resources more efficiently as we go forward. We compare ourselves constantly to national standards. We're doing that on an ongoing basis. Right now we have Huron and BRG here helping us do that across the enterprise. They told us, you guys aren't going to be able to make it with this approach. You need to change your skill sets, you need to change your labor model, you need to change the way you use resources as we go forward, and we're implementing those changes to bring us to best practice for places like UTMB. If we spend the money on keeping people we don't need, we're continuing to invest in being less efficient. That's not very smart, at least from my perspective. It's a hard thing to do to eliminate jobs, and we haven't eliminated that many, less than 100, compared to the 700 and 800 by other big systems in this area. We want to invest instead in growth opportunities, like the one in Webster. Again, there's some risk associated with these sorts of investments, but we believe these are sort of risks that we need to take to ensure that UTMB has a bright and successful future course. So in any case, I'm more than happy to sit down with any group or any individual that has concerns about what we're doing, but I just wanted to address that and tell you, people are asking me about that, give you my response, and just let you know I certainly am willing to talk more about it if you have more concerns. All right. Yesterday, we actually saw patients in the MD Anderson building in our clinic. Their building is open there, and we're very excited about that. Now, it has been I consider long, certainly at times tortuous path to get to this point. And I've said before, no two UT health institutions have ever collaborated like this. It's a true operational collaboration. There are some existing collaborations, but basically they involve the sale or purchase of intellectual property, MD Anderson's to another health institution. Truly working together is something no two institutions have ever been willing to take on because it's really hard. Now, some of you have heard me say before, collaboration is messy and time-consuming and not for the faint of heart. And I believe the people who have been involved in designing this collaboration would second every one of those beliefs. But we've done it. Now, we've had to give up some things in the process. MD Anderson's had to give up some things in the process. We've had to do some things that we didn't initially think we would need to do. But right now we stand with the doors open, patients coming to see us, and we think there's a huge upside to this. The UT system is excited about it because we're making it work. And they believe what we're doing can be the model for greater collaboration between UT health institutions, in between each other, as well as with other health organizations in the future. So congratulations and thanks to all who have been involved. It's not been an easy path, But thank you so much for getting us to this point, and we're going to very aggressively pursue that upside as we move forward. All right, we've actually started our inpatient expansion at League City. We're adding about 60 beds in total. So we're up, I believe, now to the second level. And what we're doing now that we have Webster is thinking about which services are distributed at what locations. From an operational perspective, it never makes much sense to do one thing at more than one location. Now, you can't absolutely make it a prohibition, but to the extent that we can plan to invest in certain programs, being at certain places on the mainland, and investing in the development of our programs at those places, we believe we can be very successful moving forward. So we're engaged in thinking about that now with our health system leadership, with our faculty leaders, with community physicians. A big opportunity here is for the first time for us to have a significant collaboration with community physicians. As we go forward, and as health systems continue to affiliate and come together, we believe it's inevitable that UTMB physicians will need to work with community physicians within what's defined as a larger approach to delivering healthcare in a region. So we're now engaging community physicians. We believe this is a huge opportunity and necessity for us as we go forward. Outpatient clinics, I mentioned that our MD Anderson clinic moved forward yesterday, seeing patients for the first time. We're actively involved in planning the expansion of our town center clinic in League City, essentially doubling the size of that clinic in support of what we do at League City, and in some cases League City and Webster and even Hamilton, Danbury. So very excited about those developments and more to come as we finalize our plans for the use of those facilities. I got a chance to walk through the new health education center yesterday. Wow, I want to go back and be a student again. It is absolutely awesome. It's a beautiful space, big, wide passageways, a lot of room for students to come together, either in quiet settings or noisy and busy ones. You know, I think we've talked before about the current concept in education is that a lot of learning occurs through collisions. People coming together, students and faculty members coming together, often in an unplanned way, sharing information. And there's as much informal learning as there is formal pedagogical learning. And so this particular facility, did I get that right, Dr. McClellan? Okay? Okay, he's shaking his head okay. There's a marvelous capacity of this facility to enable structured as well as less structured learning in a variety of settings. So it's going to be really cool. We should be in there by about this time next year using the facility. A lot of opportunity for simulation. I got a chance to walk through the areas for the ORs, for the ICUs, for the small learning studios, for some of the study spaces as well as the common spaces, and I think it's just going to be fantastic. So I'm very excited about it. We have new faculty lounges that are open. This has been a desire for our faculty to have some places where they can gather in private and have discussions about their faculty work or patient issues and the like. We opened the first one on the 6th floor of the Clinical Services Wing a few months back, and then yesterday we opened the faculty lounge, which is just off Cafe on the Court, the John Seeley Annex in the main John Seeley Hospital. So both of those are accessible using the faculty ID badge. And again, they're available for informal get-togethers or on occasion formal ones. And so we're very excited. We're working on a plan for a more significant faculty lounge. We think as we downsize the space that's necessary to keep books in the library, that the library we have on campus is a nice centrally located opportunity to create a new faculty lounge. It has some beautiful views out the windows. So we're moving forward with that particular plan. More to come on that. All right, shifting gears. Financial challenges. We talked about this a lot. I think I stood here in early to mid-January and talked about the potential for a $45 to $60 million loss We know a lot about the drivers behind that loss, the impact of Hurricane Harvey, its prolonged impact in terms of the way people chose to seek care. Fortunately, we've seen a reversal of some of those trends. We think they're moving back towards more of a normal pattern. That said, we have continued challenges relative to reimbursement and creating efficiency. But bottom line, we did okay. Now this is the traditional format we've been using. Remember that we've got the previous fiscal year, in this case it's to the just completed fiscal year. We've got actual for both of those, and the comparison, how we did in 17-18, the variance, if you will. And we've got 18 versus actual versus 18 budget, and the variance here. So if you want to skip to the bottom line result, adjusted margin, bottom line, go to right here, actual, budget this. We beat our budget by $200,000. Congratulations. You can see, we still had issues here in the academic enterprise and health system relative to the previous year, but we did okay relative to budget all in. And so we had a good year. What were the drivers? What happened after January to enable us to create this positive result? Well, everybody worked really hard to take a look at expenses, plans for hiring, how we were using resources, and to the extent that we could modify those and make ourselves more efficient, we did. Our volumes improved. Those trends started to reverse. Certainly, we looked at access in our clinics. We looked at getting in people who would need more acute care. We I think, did a better job of triage or improved our triage systems. And so that helped get more patients into our facilities for care. We saw an increase in reimbursements based on higher acuity care, again, a reversal of the post-Harvey trend. And so all of these things were a result of efforts that we undertook to try to improve our financial outcome. Have any of you seen, I think it was one of the recent Pulse videos I did where I said, we made our budget, but part of it was luck. Okay, well, here's the luck part. We got a favorable settlement for a Medicare cost report. Now, every year we have to report to Medicare all of our costs. There's all sorts of auditing back and forth. Typically, these things lag in terms of final determination. Some years we're up and we're in a winning mode, and some years we're down, we're in a losing mode. We always do our best. It's just kind of based on some of the nuance associated with Medicare reimbursement. Well, last year we were positive. Yay for us, good luck. John states worried, I apologize. Okay, well, you did a great job in counting, okay, but the system moves around. No offense. All right, so more savings than expected in depreciation. Now, we've talked about depreciation a lot. Sometimes it's difficult to understand. Bottom line is, the more you create with renovation, purchases of new equipment, small pieces of equipment to large investment in new facilities, the more your depreciation expense. Depreciation just makes you put money aside for replacing facilities and equipment over the course of time. We didn't finish all of the big projects. We moved along, ran into some barriers, so we saved about $20 million in depreciation expense last year. So good luck. Lower than anticipated utilities costs. That goes up and down too. We're benefiting right now from the reduction in the price of oil and the adjustment in utilities rates, and so that's great. Somebody, though, who works in the oil industry told me a couple of days ago that they expect the price of oil to go back to $100 within the next 3 years. So plan on your utility bills rising, your gas costs rising, those sorts of things, if that forecast holds up. Finally, higher than anticipated net investment income, largely driven by royalty income. Actually, we were about $20 million positive here. So between depreciation, positive 20, and the bottom bullet there, positive 20, that was $40 million swing. So that's why I say it's good luck, but I'm going to take it. That's okay. Again, congratulations for a good outcome. All right, so where are we going with 19? Well, our bottom line that we plan for the budget, exclusive of what we will do in Webster, we're still finalizing our plans here. We have what's called a pro forma financial statement, which essentially is a forecast based on what we believe. There's some drivers for that. We're now adjusting that pro forma based on what we believe will be the service assignments in Lead City and Webster. So more to come on that front, but exclusive of Webster, our bottom line target is $2.1 million to the positive. Now we believe, we know, we will continue to need to manage our costs that drive for efficiency. Reimbursement has plateaued, and per unit of clinical service, we believe it's going to continue to fall. So as that goes forward, our resource utilization relative to unit of clinical service also needs to go down. So mirror that downward trend. So we'll continue to focus on that. With regards to Webster, we think we have an opportunity there. If we can get our plans in shape, and do it right, we can execute our plans, having positive cash flow in a couple of years of startup. So again, we're working on that pro forma now, but we'll be, during the course of the next year, looking at our financial outcomes exclusive of Webster, and then with Webster included. Since we know there'll be a loss on the Webster investment initially, bottom line, we'll have some sort of loss. We're just not quite able to quantitate that yet. But we want to make sure that we look at that a little separately because it is a startup operation and it's moving out of sync with our regular budget. All right, so those of you who have seen my most recent Pulse video know that we're moving forward with our plans for a merit pay adjustment as we plan. This will occur in the November timeframe, so those adjustments in compensation will become effective in early November, the 1st or the 3rd, depending on your pay cycle, and then you'll see that in a paycheck either in late November or early December, again, depending on your pay cycle. These are the pools that are out there, so 3% for the non-teaching and classified personnel, 2.5% for administrative and personal. These are the administrative professionals, and then these are those effective dates and paycheck dates. Now there's a note here, obviously the amount of an individual's pay adjustment will depend on their supervisor's recommendation. So what I'm describing here are the pools that are available, and within those pools, recommendations will be made for adjustments for each individual. Now I want to remind our CMC folks that their compensation is managed by the legislature. Dr. Ojo, I think we just had a relatively recent adjustment for our CMC folks. What we're doing with them is not going to be impacted by this, but certainly we're going forward into the legislative session, which will start in January, planning to ask for additional increases so we can support our CMC employees. Yeah, well, absolutely, and that's a very important thing to do. We'd like to be able to manage those on our own, but right now, the way the state funding system works, we can't. I also want to remind you that faculty and executive pay are not considered parts of these pools. The faculty comp plan, if it's incentive plan, moves separately, as does the executive system and its incentive plan. And what we do with both of those in general is every year look at the market by position or by specialty or by department, by educational type, and try to make sure that we're aligned with the market needs. The challenge with each of those groups is there's so much diversity. Some are peculiar to an academic medical center, and some are in common with academic institutions in general. And within the executive group, it's the same. So we have a lot of diversity among the different classifications and descriptions of people, so we manage them a little separately. Anyway, I just wanted to put this up and commit to it. We'll be working with our managers and supervisors now to manage these pools as we complete our evaluation cycles, and hopefully this will be good news for our employees. Team awards, also announced this with the Pulse video. For the people who are eligible, we will we'll provide a $750 payment, which will be paid out on November 16th. The recipients must meet all the eligibility criteria and cannot be a participant in faculty conference, incentive plan, or executive and AAP at-risk compensation plan. So basically, this is a tremendous thank you for all the great work to help us meet not only our financial goals, but all of our goals in a challenging time. So thank you to everybody and congratulations. Very pleased that we can do this again. All right, so bottom line to me, where do we stand right now? Well, we have a lot of really rich information about the needs and desires of our employees that came to us through the U-Count survey. So we have a marvelous opportunity to act on those as we go forward. I want us to do that. And keeping in mind, this is not a grade. This is a description of an opportunity for us to be more successful, do a better job. Welcome to Chief Adcock. So glad he's here. Best care results on track. I think we've probably done pretty well again for FY18. We'll know more after the first week in October. And let's continue our work to be a high-value providing organization across all of our sites, no matter our mission focus. Our priorities for FY19 have been established through the institution-wide planning processes. We'll be putting out our more specific goal sets associated with our plans in the coming weeks, but in general, we think that those priorities are well aligned with institutional needs. A lot going on as usual with our facilities, making progress that will help us better support the needs of our patients and programs as we move forward. And finally, we had a crazy year financially, but we ended up in a good place thanks to hard work and a little bit of luck. And hopefully we'll be able to continue to do that moving forward. I think we understand what our challenges are. Now it's a matter of all working together, hopefully absent as much cynicism and sarcasm as we can avoid, to make our plans for how we respond to the challenges that stand before us and academic medical centers in this country. You know, the great thing about this institution on multiple occasions, even in my a little over 11 years here, it has always stood up to challenges, responded very well, and in every case that I can think of anyway, come out on the other side of the challenge in a more favorable position. That is just totally attributable to the marvelous people we have here and the way we work together, and I hope that we can continue to do that as we move forward. So thank you so much for all of your great work in the past fiscal year, and look forward to what lies ahead. All right, so we do have a little time for questions. Any questions from the audience right now? So let's be thinking about those. I know we have a couple that came in through the EAC portal. I know one was about what are we doing to protect our employees? You know, we're living in a time where there seems to be more anxiety and more anger, and more of a willingness to physically express frustration. That puts our people more at risk, particularly since we're a public institution and open to anybody. We also know that, at least within the health system, we're delivering services in what often are emotionally charged situations, which increases the threat level for our people. So I've had a couple of questions sent to me by members of the nursing staff. We've actually had some of our staff who have been attacked by patients, taking a swing at them, or in some way confronted them physically. A couple of cases, I believe, there have been family members who have made threats to our staff. We always respond. We actually have what I think is pretty good policy, which basically says we will not tolerate that and take whatever steps necessary to protect our people. It's one thing to have policy, it's another to use it effectively. I know the chief is very concerned about this. Chief Adcock, would you come down maybe and come to this microphone here in the center and just kind of talk about your thoughts about that, where we stand today, some of the things that you all have already done as a police department, how we want to manage this going forward. Thank you.
Thank you, sir. Well, good afternoon, everybody, and thank you for the warm welcome. So, as Dr. Callender mentioned, the institution takes a zero-tolerance stance when it comes to workplace violence, particularly as it relates to our healing environments in the hospital. And we know that that can be an issue. As a matter of fact, national surveys have shown that healthcare workers are 4 times more likely to suffer workplace violence than any other profession, so we recognize that that's an issue nationally. Our institution has made very clear that that's not something that we tolerate. So if you ever feel threatened, what I would say in this short amount of time that we have, if you ever feel threatened in any way, before it gets to the point, if you're able to, before it gets to the point where it escalates to somebody being touched in any way, we would ask that you contact the police department and we'll respond immediately. So as Dr. Callender mentioned, we've added staffing to help provide for that, and that has allowed us to actually assign an officer into the hospital on foot. So in addition to the officers that you see driving around campus, we have officers actually on foot in the hospitals 24 hours a day, which will help them get to you faster should you feel the need to press an emergency button or pick up the phone and call the police. We're going to get there fast. Currently, the response time for a panic button is under 4 minutes. So it's already pretty fast. With the officer actually posted in the hospital, it should get even quicker. The other thing is we've got some technologies designed to help you be safe and feel safe, and that includes our UTMB Safe app, and there are cards out in the lobby, so if you don't already have access to one of those applications, please feel free to pick up a card, and that provides 2 primary programs. Number one is a virtual walk to your car, where you can get on the app and we'll actually stay in contact with you to get your car, or actually come pick you up and give you a ride. So there are some other programs available, and just want you to know that we're all committed to keeping you safe, and we're here for you if you need us.
Chief, we should talk about a couple of things. Number one, talk about the bike patrols and the effort to be more visible.
So the other thing that we've done, as Dr. Conn mentioned, we're trying to make sure that you see us more often. So there's very little crime that actually occurs on campus. We track that very closely. Very, very little crime occurs on campus, and virtually no major crime. So no really serious crimes, have happened in a long time on our campus. So you have a very safe campus. We have a very safe campus. But it's not just enough to be safe, you have to feel safe. So the perception of safety is something that we're interested in. So when we hear nurses on a particular floor say, hey, we're not so sure we're safe, we want to address that. So we're doing things to appear more visible, and that includes that we've implemented a bike patrol. So those officers are being selected and trained now, so you'll see officers on bikes more. We've marked all of our cars, so you'll see more marked cars. The cars that are unmarked that actually give people rides, we put amber lights on them, so at night they show up, and the bad guys, if they're on campus, will see them, and so will you. You'll know when they're coming down the street, and if you need help, you just raise your hand and they'll come help you. So we're doing lots of things to provide extra visibility, to include the bike patrol. And then in addition to that, the additional staffing that we've added has been mentioned, they're all boots on the ground. So these are people that are going to be providing direct services to you. These are officers, additional police officers, additional security officers. So these are people that you'll see more often. It'll just help build the feeling of safety and true safety on campus.
The other thing, Chief, and you and I talked about this the other day, this was actually in a couple of the notes that were sent to me. In some cases, we've had police officers who have responded to a threatening situation or one in which there actually has been an act of violence. Fortunately, we're not having anybody really seriously injured, but there have been some injuries. And in some cases, the staff member felt like the police officer put them at a disadvantage by asking in front of a family or a patient, do you want to press charges? And so you visited with me about that. I thought your response was great. Would you please just talk about that?
Absolutely. So that is one of the questions that was raised by a member of the nursing staff. They sent it on the blog, and we did our best to respond to it. So in this particular case, the nurse felt like, I believe it was a male nurse, felt like, he had been assaulted by a patient. Of course, we don't tolerate that, and the officer came in and asked the nurse 2 questions, actually. And one of them was, did you feel pain? And the nurse felt like that was an out of the ordinary question. And then the second question was asked in front of the family and in front of this patient, and that is, do you want to press charges? And I can understand how that would have placed that nurse in a very awkward situation. So there are 2 points here. Number one is, why are those questions being asked? And so I'll share those with you. Those questions are required to be asked. So the officer does have to ask both of those questions. The reason being is that it's a whole different level of offense if somebody is, somebody makes contact with somebody and it doesn't hurt them, but it's very offensive, like somebody just elbows you or something. You're not really harmed by that, but it's very offensive. That's a criminal offense, but it's a Class C misdemeanor. But if you feel pain, it's a Class A misdemeanor. So it's a whole different level of offense. So the officer has to ask that question so he or she knows what the crime is and what do they document in the report and what do they contact the district attorney's office on it. So I think in this particular case, we just weren't communicating with each other. We just weren't explaining why that question was being asked. And it was a little offensive to the staff member, and I can certainly understand that. The second one that Dr. Callender mentioned was the asking the family if they want to, or asking the staff member if they want to press charges. That's an essential question. It has to be asked because the district attorney is going to ask us that question, and it has to be in the report. Does the victim want to press charges, or are we trying to pursue charges on behalf of the victim, even though the victim doesn't want to press charges? The district attorney is interested to know that information. We have to be able to answer that question. But what we don't have to do is ask that question right in front of the family, right in front of the suspect, and those sorts of things. And so we've conducted training with our officers and explained that to them, because to them these are very routine calls. But to the individual staff member, this is a very significant event, and hopefully something that you don't have to go through very often at all in your career. So when it does happen, it's a major issue in your life, and so we have to recognize that, our officers have to recognize that, and we have to be more sensitive to that. So we've conducted additional training, and I think it's going to help.
Great. Thank you, Chief. Any other questions for the Chief on that particular subject or subjects? All right, thank you, Chief.
Thank you, sir.
Appreciate it.
Good afternoon. Bob Dalecki with Correctional Managed Care, a member of the Employee Advisory Council, and we received a few questions.
Okay, thanks, Bob.
These questions were compiled as of September 17th, and I'm reading them in the order that we received them. So the first question is, why weren't patients notified in writing of the closure of the medical weight loss program? The only way patients found out about the closure, which was effective on August 31st, 2018, was by word of mouth or phone calls from the Center for Obesity and Metabolic Surgery. Isn't standard practice to give patients a 30-day written notice?
In this particular case, as I understand this, and thank you for the question, whoever submitted it, the center is restricting its activities, so the surgical activities will continue, but the medical weight loss portion of the program is being eliminated as a formal program. So it's a different sort of notification process. What I'm told is that patients were either contacted by telephone to discuss this and given an option or several options for how their follow-up would occur, or this was provided to them, the information was provided to them at a clinic visit. There actually is no formal written notification process, but given this concern, I believe the plan now is to go ahead and formally notify the patients in writing about the change, about the options that are available to them. And then hopefully everybody will have a better understanding of what's happening. Patients in particular will feel like they're better informed. So thank you for whoever submitted the question. Really appreciate that.
Thank you.
Okay, anything else? All right, thank you all very much. Thank you for your great work. Have a great day.
Working together to work wonders.